Good day, dear pharmacists. Today we are going to start for paper 2 lectures. For sure, we will, as you all know, paper 2 consists of two main sections. The first one, which is the pharmaceutics, and the second one, which is the therapeutics part. We will discuss in the next lectures the part of pharmaceutics. Mostly it would be 2 to 3 lectures, no more. Also, there is a calculation part which is divided equally between pharmaceutics and therapeutics, which is already uploaded on the website. And now, after we finish the pharmaceutics, we will go directly to the therapeutics. Okay, so let's start then. For the pharmaceutics part, we mainly discuss and we will illustrate the pharmacokinetics in the body: absorption, distribution, elimination, excretion, and metabolism. Also, we will discuss the dosage forms, route of drug administrations, the surfactants, all those related topics. Just as a reminder, all the highlighted in red topics are very important. It's frequently repeated questions. So the first thing we will discuss today is the pharmacokinetics. Now, the pharmacokinetics part is related to absorption, distribution, metabolism, and elimination. We'll go first for the absorption. We have two main parts, two main branches for the process of absorption. The first one, which is the passive absorption, and the second one is the active transport. The first one, which is the passive diffusion, let me show you here. Simply, that process does not require energy, and it involves the transfer of the drug from high concentration to low concentration with the concentration gradient, so there is no energy required. The best example for that is a drop of ink in a clear water glass. When that drop enters the glass of water, it starts to diffuse till all the cup become the color of ink, which is light blue or light black according to the natural color of the drop itself. That's the easiest way to illustrate that. The drop with a high concentration comes into the glass of water, which is low concentration or non-concentration. Then the concentration starts to diffuse, the medication starts to diffuse from higher concentration area, which is in the middle here, to the surrounding media till all the cup becomes saturated with the same concentration of that particle. Let's go back to the process. The passive diffusion is the main route of drug absorption. So the definition here, it's the transfer of a drug from an area of high concentration to an area of low concentration with the concentration gradient, according to the concentration gradient. That phenomena occurs to the majority of the drug. The lipid-soluble drugs cross the biological membranes, and water-soluble drugs penetrates the cell membrane through aqueous channels. Let me illustrate and emphasize a point here. Mainly, for a drug to be absorbed, it has to be in lipid. Sorry, I need to be in lipid soluble form. Okay, so the drug need to be in a lipid soluble form. That means non-polar. That's the case for absorption. Now, for metabolism or for elimination, it has to be water soluble and polar structure. So for that point, first it has to be okay. I have water soluble and polar structure. That's one for absorption, and that case for elimination. In between the process, those two important processes, we have the metabolism. In between, we have the metabolism, which is the liver converts the lipid soluble structure or medications to more polar water soluble, easily excreted medications. This is the most important base that you need to know in regards to the whole pharmacokinetics. Let me now link that base with the topics we are discussing at the moment. So we have mentioned that the lipid-soluble drugs cross the biological membranes, and water-soluble medications just penetrates the water channels across the membranes. What we are discussing here is the transfer of the drug from absorption site, which is the stomach and small intestine, to bloodstream. Okay, so this is the membrane between those two parts, the membrane of stomach cells and membrane of the small intestine. We need to cross that so we can get into the bloodstream. Okay, this is what we are meaning by that. So that process does not involve carrier, non-saturable. There is no saturation at that process, but there is an equilibrium. What's the meaning of equilibrium? If the drug at the absorption site and on the other side in the blood has the same concentration, so the process will stop automatically. So we have high concentration here, low concentration here. After 1 hour, it will be maybe, for example, 9 here and 5 at the other side of the blood. So that means that there is still passive diffusion processes going on. When we reach that amount here is equal to the amount here, so that means that the equilibrium is reached. Maybe here is 5 and at the other side is 5 also, so equilibrium is reached. There is no passive diffusion. Power is still there. The process has been ceased. So the characters for that not involve carriers, no saturation, and we will know more about saturation in the active transport, and have low structural specificity, meaning there is no specific structure that follow that rule. it's major for all medications, so there is no specific structure that follow the passive diffusion. Now we have that process follows Fick's law. What's the Fick's law? Fick's law easily that the rate of diffusion, we will represent it as R, will directly proportional with the diffusion coefficient. We will give the example D, diffusion coefficient, and surface area, and irreversibly with the thickness of the membrane. We will say it as T, for example. Okay, so what's the meaning of the thickness of membrane here? We will discuss that facts now. Directly proportional, meaning if for the first one, which is a constant, which is the diffusion coefficient. It's a constant value, so it does not have anything with us. We need now the surface area. If we have an increased surface area, that means higher diffusion, passive diffusion, high surface area, so we have higher diffusion rate. Okay. Now, thickness of the membrane. If the thickness of membrane that to be penetrated to reach the blood is very wide, is very high value, that meaning the diffusion rate will be decreased. And if the thickness of the membrane is small, that has a small value, that meaning that we will have higher rate of passive diffusion. This is simply the equation. The direct proportion, meaning increase in the factor, increase in the result. Inverse proportion, meaning increase the value, decrease the result. After that, we have the direct force in the equation is the concentration ingredient. This is the main thing that we have mentioned before, that the main force here is the concentration gradient. Okay, so that one is now finished. Let's go for the minor route, which is the active transport. Let me show you something here. This is the membrane. Okay, so first of all, for the active transport, process, first thing, it's against the concentration gradient. It is against the concentration gradient. So maybe that substance that we are going to enter into the cell, maybe the concentration outside is less than the concentration inside. So this is the less and here high. With the normal passive diffusion process, the substance is moving from the high concentration to low concentration. However, for the active transport, it's the contrary process. The concentration, the substance is moving from low concentration to high concentration. This is the first thing. The second thing, it requires a transporter. Okay, it requires a mediator or a carrier or a transporter, which we show in the picture here like that, and it requires energy. That carrier does not work for free. It requires an energy. Okay. The second important thing, which is saturation, meaning if I have 10 molecules outside need to be entered to this cell. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And we have only 4 mediators, as you can see here, or 4 carriers. So what will happen is that each will occupy one mediator or carrier, then the others will stay outside, waiting for those amount of mediators to be free and finish their job so they can contact with the transporter or the carrier and go inside the cell. So that's the meaning of saturation here. If all the the carriers occupied, so the process will cease till a new or free mediator carrier are available. So let's go back to its energy dependent, as we have mentioned. Yes. Let's go back. So for the active transport, we have the yes, the process happens or occurs against the concentration gradient. This is the first thing. Second thing, it's occur for a limited amount of drug, not as the main route, such as the passive. As we have mentioned, the passive diffusion is the main route. That one happens only for limited amount of medications. The process is carrier mediated, as we have seen in the drawing here. So it's susceptible for saturation. Where the carrier is saturated, the process will become zero order. So there will be no more medication entering to the cell. It's energy dependent. Beware of all the red notes. Number 4 may be adversely affected by certain chemicals. Yes, so some of the medications can affect the transport process in a negative way by, for example, damaging the carrier or something like that. Number 5, there is no equilibrium as in the passive diffusion process. Also, there is another type, which is the facilitated diffusion. It's a carrier-mediated process, but does not require energy. Okay? Now, let's go for pH partition theory. The one I have mentioned previously, which is that the drug to be absorbed through the lipid membrane, it has to be in the unionized form, which is nonpolar, and the medication to be excreted, it has to be in the ionized form, which is the polar. This is called pH partition theory. This is a very important thing. Second, yes, now we are applying the pH partition theory. Okay. What that means that if I have an acidic, weak acid medication in the media which is acidic, that means that that medication will be in the state of non-ionization. That means higher lipid solubility. That means improving of absorption. This is the absorption case. However, if that medication, which is weak acid, placed in the same medication in a basic media, that means that that medication will be in the ionized state. The ionized state, which is water soluble, meaning polar, meaning improves the excretion. Okay, that's it. So we have mentioned now that one. Yes, for the medication, Also, there is important note here. Ionized drugs at the blood pH penetrates the blood-brain barrier and, the ionized medication at the blood pH cannot penetrate the CNS and will not have a centrally acting effect. Another thing, that the metabolism of the drug generally result in a polar molecules. That polar molecules easily excreted and have poor protein binding. Okay. Now, there is another factor that affect the absorption, which is the gastric emptying. What is the meaning of gastric emptying? Meaning that the time required from the drug to go through the gastric or the stomach. Okay, so this is the gastric emptying. So now, the first thing, which is the factors that slow gastric emptying: severe or extensive exercise, emotional stress, hot meals, and fatty food. Those factors can delay the gastric emptying time, meaning decreasing the medication absorption. The factors increase or fasten that process is mild exercise and dilated solutions, cold meals, hunger, and laying on the right side. So the factors fasten the process of food absorption and enhance gastric emptying. After that, we have the rate limiting step for absorption. What's the rate limiting step? Usually the slowest process, it is the rate limiting step. The whole process of absorption will be dependent on the slow process. And that process actually different from medication to another. So, for example, we have the tablet. The tablet goes through 4 or 3 steps. The first one, which is the disintegration, which is the process of transferring from the tablet, compressed tablet, to powder form. This is the disintegration. As we all know, the tablets are solid because of the hard compression. So the tablet requires a process first, which is called the disintegration. The disintegration is the transfer of the drug into a fine powder. After that, the dissolution, which is the process in which the medication in the powder form starts to dissolve in the solution to form an absorbed solution. After that, the process of absorption starts. So as we see here, the dissolution, where small particles or fine particles are disintegrated, which are disintegrated, are exposed to fluids of the gastric intestinal tract to be dissolved. That process follows an equation, which is, its name is very important. Its name is News-Whitney equation for dissolution, which is at that equation, it reflects the rate at which drug dissolves from the surface area of the solid mass, followed by diffusion through the layers that surrounding solid particle. Okay, so the most important thing here that the News-Whitney equation is suitable for or describes the process of dissolution. Now we have a question here, which is the bioavailability determinant in the regular immediate release tablet, which is the process that determine the bioavailability in regular intermediate release tablets. We have the dissolution, disintegration, metabolism, and we have mentioned that the rate limiting step is the slowest process that would be determinant for the absorption process and the bioavailability of the drug. We have the after that the adsorption is a physical phenomenon. Adsorption meaning that the substance stick on the surface of another substance. That's usually an example for that is the activated charcoal, which is administered to decrease the toxicity of other agent. We take the charcoal, activated charcoal, because it has the ability to absorb other substance on its surface and easily excrete safely the charcoal with the other substance and prevent its absorption. Now, ranking of the absorption or dissolution by the medication dosage form. So which one is the fastest and which one is the lowest? We will start from the fastest, which is the aqueous solution. Why it's the fastest one to be absorbed? Because that one has no disintegration process. And also no dissolution process. It goes directly to absorption step. Why? Because it's already dissolved in liquid aqueous form. So it's as soon as it's ingested or administered, it will be absorbed immediately. So this is the first and fastest process in the absorption state. Second one, which is the suspension. The suspension needs dissolution so it can be absorbed. After that, the powder, loose powder, because it will go for the dissolution state immediately. After that, the capsule. The capsule, we will have a time for the degradation of the capsule shell, and then the powder inside is released, so it will go for the dissolution after that. After that, we have the tablet, which is the compressed tablets. That tablet will go first for the disintegration, then the dissolution, after that the absorption. So it has multiple steps, so it will be slower. More, we have the coated tablet, which we will need to dissolve the coat first, then we will have a time for the tablet to disintegrate, then this dissolution process, then the absorption. So the fastest one is the aqueous. The slowest one will be the enteric coated. Sorry. Yes. Now for the distribution. Now we have finished the absorption process. Now we will go for the distribution. We have its apparent volume of distribution expressed in liter. Why it is apparent volume of distribution, not volume of distribution? Because it's apparent value, it's imaginary value, it's approximate value. Okay, so How is that? The factors affecting the volume of distribution. The first one, which is that the volume of distribution will be greater for the drugs that's concentrated in the tissues rather than the plasma. It will have a higher volume of distribution because it's spread in tissues. So it will have higher number of parent volume of distribution. However, the medications that is has the property of protein binding, it will have less volume of distribution because it will be mainly in the plasma and the blood only. Okay, so what are the characters of albumin? It binds with the acidic functional groups. Okay, so mostly the albumin binds with the acidic functional groups. Second thing, sorry, it is saturable. The albumin is saturable, meaning that the medication need to be. I will explain that in a minute now. Okay. Also, we have. Yes, this is the explanation here. We need to have a loading dose for the drug to be in high saturated protein binding state. Okay, so this is the reason. Because the medication, when it binds with the albumin, it's in the inactive form. That state cannot be pharmacologically active. So due to that, we have to saturate all the amount of albumin by binding with it. Then the free form of drug that is not binded with the albumin will be acting as medication and in the active form. However, we should avoid protein displacement, because if displacement happens due to another medication, because as you know, the affinity of binding with the albumin different from medication to another. So if there is another medication which has high affinity with the albumin binding, that means it will get rid of drug A and bind with drug B, which has the higher affinity for it. That will cause the issue, which is high amount of free active form of drug A that is unexpected to be in the body at same amount of time. That can cause toxicity. So we avoid the displacement. Also, high protein binding. Yes, I have mentioned that the high protein binding decrease the free drug available for elimination and for action also. Drug with no protein binding, such as the allopurinol, can be safe with administered with other medications. Now we will mention and discuss the metabolism. The metabolism, we have the metabolism is mainly the process of converting the absorbed nonpolar drug into excreted polar drug. Okay, this is the summary of whole the process. So we have the hepatic first pass metabolism effect, drugs that are hereby, that's place, that area, drugs that are absorbed from the gastrointestinal tract are generally absorbed in the portal circulation, pass through the liver before entering the general circulation. So the route of administrations, we have the oral, most affected by the first pass effect. So, by the way, oral medications, any medication that has been administered orally is metabolized first, then distributed. Okay. However, there's some medications that skip the metabolism process. The first one, which is the inhalation, transdermal batches, injections, and sublingual. Also, the rectal route. Some of the medication, proportion of it, absorbed and act and skip the first pass effect. So let me show you something. Sorry, I will illustrate that now. Just 1 minute. Yes, we have that diagram, that shape, that picture. So if the medication is absorbed, taken orally, that means it comes into the stomach, absorbed from the intestine. Here is the liver. Okay. So the medication is absorbed and it's going that way, going to the liver, being metabolized, then going to the lung. That's the deoxygenated blood, goes from the deoxygenated to be oxygenated, then going back to the heart, pump all over the body from the left ventricle. Okay. And through the aorta. Now, so at that case, the medication absorbed is metabolized first, then distributed. Okay. So for the other route of drugs, we have the inhalation. The inhalation, it goes either straight to the lung. So if the medication is coming to the lung directly, it will go to the heart, then distributed and metabolized. So that meaning that the inhalation medication does not pass through the did not go through the first pass metabolism. Also, transdermal batches, it follows the same rule. It goes directly into the non-metabolized areas. It goes through the oxygenated system and distributed directly, then metabolized. Also, the sublingual tablets from the buccal cavity directly to the heart and blood vessels to be distributed, then metabolized. For the rectal route, here, there is two veins, one going for the liver and the other one is going for the heart. Some of proportion of that absorbed medication going through the first one and the other proportion going through past the liver, going through directly to the heart. So that's why some of that medication, which is taken rectally, bypass the liver metabolism. Back again. So now we have the examples of, yes, before that, at the liver, as we have mentioned, that proportion of the drug is metabolized converted to the excretion form, then the remaining of that substance will act as medication. The amount that escapes the metabolism is the amount that will give the effect. Then, upon going through circulation again, that amount will be degraded and excreted. So the first dose, the dose which is given to the patient, is metabolized first, then distributed. The acting amount, the affecting amount, will be the amount remaining from the metabolism process. We have an example of drugs that affected by the first pass effect, which is the lidocaine, propranolol, nitroglycerin, and morphine. Second, we have some examples that are not affected by the first pass effect, which is the phenytoin, acetyl salicylic acid. Now we have an important note here, which is the inhibitors. We have there is a liver microsomal enzymes that are responsible for the drug metabolism. Okay. So those enzymes, those medications inhibit the action of the metabolism. So in turn, it will increase the duration of action because the amount of drug metabolized decreased. Example for that, erythromycin, ketoconazole, also grapefruit. Grapefruit, the example here, grapefruit is contraindicated during the use of atorvastatin because it increases its action, may lead to toxicity or severe side effects. We have the inducers, medications that increase the activity of liver microsomal enzymes, in turn causing decrease in concomitant administered drugs because it's extensively metabolized by the liver. Those medication examples are phenobarbital, rifampicin, phenytoin. Okay. Now, the bioavailability, it's defined as the relative amount of drug that reach the systemic circulation. So, relative amount of drug that reaches the systemic circulation. How can we measure that? By the area under the curve or the urine excretion data. In it, we collect some of the drug in the urine and the urine excretion ratio. Okay, so now the estimating bioavailability for urinary extract data is less satisfactory than estimated based on blood level. That's because to determine the urinary excretion data, we need a complete urine collection, which is not suitable, and normal or nearly normal renal function. It has to be, so it's not suitable for the patient that are renally compromised. Okay. So for the notes here, we have, although urinary excretion data conducted mainly on drugs that primarily excreted unchanged, by the kidney, it's necessary that the drug be completely excreted unchanged by the kidney. Okay? So this is one of the important things, that to measure the bioavailability, we have to measure that the drug is renally primarily excreted unchanged, which is not the case for most medications. Also, the use of urinary excretion data to calculate bioavailability is based on the assumption that a drug must first be absorbed into the systemic circulation before it can appear into the urine. Okay, that means that for the other type of drugs, sublingual patches, or those things will not follow that rule. Absolute. Okay, let's go then. Absolute and relative bioavailability. What's the absolute bioavailability? It's the comparison between amount of drug absorbed with the standard amount presented in the blood. Mainly, we compare between the area under the curve of oral or any other type of medication by the absolute amount which is given as an IV. This is multiply 100, as we can see in that equation. So this is the absolute bioavailability, meaning we measure the oral or sublingual or any form of medication in compare with the amount of drug administered intravenously. Okay. So for the bioavailability factors, it should be not should be, but if we compare the bioavailability of the intravenous with another medication that's also 100% absorbed, should be 1. The ratio should be 1. Okay, so that's the main thing, that we compare the oral route, for example, with the intravenous route multiplied by 100. That's it. Okay, so for the relative, we compare two different standards, meaning we have the area under the curve for oral 1 with the area under the curve for oral 2, for example. So that's called the relative bioavailability, the availability of the drug for a specific formulation in compared to reference standard is administered at the same dose level. Okay. So that standard for the oral drug is usually solution of pure drug. Usually that one is used for the generic and branded products. This is the main use for the relative bioavailability. However, the absolute bioavailability, we measure the relative or the compared amount of drug when taken intravenously and orally, mostly. Okay. So we have an important definitions here. The bioequivalent medications. For two drugs to be bioequivalent, they should have the same area under the curve, which means deliver same amount of drug, and they have the same bioavailability, of course, or same time to achieve peak blood concentration. Same time to achieve peak blood concentration. We have the therapeutic equivalent has to be safe and efficient. For the pharmaceutical equivalent, this is another substance. The characters for that, they have the same active drug, same therapeutic moiety. They are same salt or ester or chemical form, same dosage form of the drug and same concentration. This is the pharmaceutical equivalent. Okay, which is we say it in the pharmacy as generic. This is the pharmaceutical equivalent, which is the generic form of the drug. Has to have the same active ingredient, same salt or ester, same dosage form, and same concentration. The bioequivalent, the only two conditions, they achieve same amount of drug and same peak time. They are different in excipient, color, shape, or packing only. This is the main difference in the generic or pharmaceutical equivalent. Okay, after that we have the prodrug. Prodrug, that's the compound that converted to the active form inside the body. The example for that, the enalapril and the clonazepam. So also this is the definition and area under the curve too, so you have an imaginary picture of that. The area under the curve, which represents the concentration of the drug versus the time. And it can be used as a measure for bioavailability. Okay, so I think that will be enough for today. And we will start in the elimination process in the second lecture. Thank you for that and wish you all the best.